I'm Dr. Neil Skolnik, and today we're going to talk about the American College of Physicians Clinical Practice Guideline on the treatment of depression. Depression is a frequent flyer in primary care. 20% of adults over their lifetime have depression, about 10% in any given year, and it's gotten worse since the pandemic. Also important is that 80% of antidepressants are prescribed by primary care. We're not going to talk today about the diagnosis of depression, which is important, but we're going to focus on the treatment. First, you want to make sure that the patient has depression, not bipolar disorder. Then gauge the severity of depression, mild, moderate, or severe, depending on someone's symptoms and functional impairment. It's also important to recognize that once treatment is started, it can have either no effect, a partial effect, or a full effect leading to remission. Since the majority of people that we start on treatment don't achieve a full remission, it's really important for us to be comfortable with second-line treatment for people who don't fully respond. Let's start with the recommendations for treatment of mild depression. Here, the recommendations are cognitive behavioral therapy, or CBT, over medication. And that's because the evidence is good that CBT works as well as medication, but you don't have side effects. If CBT isn't available, then second-generation antidepressants such as SSRIs, SNRIs, or other medications, bupropion, mirtazapine, and some of the newer agents are all options. Remember, aerobic exercise helps a lot at improving depression. Initial treatment of patients with moderate to severe depression is either CBT, a second-generation antidepressant, abbreviated SGA, or combination therapy with CBT and a second-generation antidepressant. There's no difference in efficacy between CBT and antidepressants. And remember, CBT has less side effects. There's also no difference in efficacy between the different second-generation antidepressants, but there are important differences in side effects. Remember, common side effects with the use of antidepressants include GI side effects like constipation, diarrhea, nausea, as well as other side effects including dizziness, insomnia, fatigue, and sexual dysfunction. Some notable differences among the different medicines. The SSRIs often lead to a loss of appetite, sexual dysfunction, and insomnia. Mirtazapine often leads, unlike the SSRIs, to weight gain instead of loss. And mirtazapine is a bit sedating, so is useful for people who have trouble sleeping at night. Both bupropion and mirtazapine don't have any side effect of sexual dysfunction, and the SNRIs are good choices in people who suffer from chronic pain, and they seem to have a beneficial effect on people with attentional issues. Because 70% of people don't achieve a full remission with initial treatment, it's important for us to know what the next steps are. For second-line treatment, we have some choices. We can switch to or augment therapy with CBT if we didn't use it initially, or we can switch to a different second-generation antidepressant or augment what the person is currently on with a second medication. Usually that second medicine is going to be either mirtazapine, bupropion, or buspirone. Some general considerations include starting with a low dose of medicine, seeing people back frequently, and then titrating up to the maximum dose of antidepressant medicine. We should be monitoring for new or increases in suicidal thoughts during the first 1 to 2 months of treatment. And then once remission is achieved with medical treatment, then antidepressant medicine should be continued for at least 4, usually 9 months. And if it's not a first episode, but a second or third episode, then medications need to be continued longer. For patients with severe symptoms or those who do not have a full response after second-line therapy, referral to a psychiatrist makes sense and is important because there are other treatments that are available that aren't covered in the guidelines. Those treatments include other adjuvant medicines, transcranial magnetic stimulation, ECT, ketamine, as well as partial and full outpatient and inpatient programs. So, in summary, If possible, start with CBT for patients with mild depression, though second-generation antidepressants are a reasonable option. For people with moderate to severe depression, use either CBT, a second-generation antidepressant, or both. And then monitor for response, titrate up the medicines as indicated, and don't be afraid to add a second-line treatment, CBT or a second agent if it's needed. I'm interested in your thoughts on this. Please leave them in the comments section. I'm Dr. Neil Skolnik, and this is Medscape.